Good afternoon, everybody. Health Information Exchange. I'm trying to get people excited about it. It is, I won't go into too much about who I am, what I do, but I want to pump everybody up for Health Information Exchange. I think I heard a few previous speakers sort of pose a few questions as well as some of the questions from the audience, and I'm going to try to convince you that Health Information Exchange is the answer to a few of those questions. So Harvard Business Review, around the time of commencement a few years ago, maybe 3 or 4 years ago, did an article, and I forget the author's name. It was sort of a contrary opinion on the traditional commencement address. Like, okay, when you're going to get up there and tell all of the young entrepreneurs and engineers and people looking to follow their dreams, give them some good sort of advice on where to go. One of the most popular things is the sort of follow your dreams. Okay, it doesn't matter how impractical it is. Like, you want to be a pan flute musician, you go be a pan flute musician and you study and you don't make any money and that's all you do and you never sort of have money to feed your children, but you're following your heart. And it becomes increasingly impractical given the economy and as things sort of real life takes over. And not necessarily to disparage that notion, but sort of an alternative to that notion the author put forth was find big problems. So find big problems that engage you personally. Because I think I heard a previous speaker say, okay, how do I pick what I'm going to do for my line of business, my entrepreneurship? Like, what do I focus on? Like, of all the things, the problems are sort of self-evident. Like, if you are looking to do something along those lines. So if you're looking to solve something, you will always have work. You will always have something to do or a new angle to that work. If you're interested in healthcare, the environment, infrastructure, education policy, like any number of these areas, the market is limitless because these are huge problems. And so if you sort of fuse your sort of communitarian ethical passions with this sense of entrepreneurship, you'll always sort of have that to go to. And somebody else suggested working for free. You can only work for free for something you care about. So if that's sort of where we're going, I'm hoping to maybe convince you that Health Information Exchange is a possibility because we're looking to build things. We have a gap because healthcare needs to be interoperable, it needs to be connected, and it is sort of a known that it is better healthcare when your various clinicians can speak to each other. They can't currently speak to each other. So once we fill that void, then everybody can rest easy. But right now, there is still an open gap. So I work for the Office of National Coordinator for Health Information Technology in the United States. I also work, I have 2 jobs, for the Centers for Medicare and Medicaid Services. Medicaid specifically, for those who don't know, Medicare and Medicaid are the 2 big public payers in the United States. Medicare is for the old and disabled. Medicaid is for the poor. So it's a little oversimplification, but Medicaid is for the poor and it's run at the state level. One of the things we did in 2009 when our economy was in a lot of turmoil was we had the Recovery Act. The Recovery Act was a massive infusion of capital and money and bailout funds and sort of various sorts of projects to help stimulate the economy. $28 billion was directed towards the adoption of electronic health records. So that immediately infused into the market money to incentivize doctors and other clinicians and hospitals to adopt electronic health records. Electronic health records are sort of overwhelmingly a front-loaded cost. So most of the barrier to adoption was that sort of front-loaded cost. Like, they didn't disagree with the notion of having electronic health records. They just, we're a clinician, maybe they're in private practice. It's difficult to justify that when you're also trying to pay your salary. You're trying to make ends meet. So the results were astounding. Adoption is great. We have 80% as of 2014 of primary care of clinicians have an electronic health record. That was in 2014, and I don't know the more current numbers. The more current numbers are probably even better than that, obviously. So our next step is interoperability. We've been working in Medicaid on encouraging interoperability and trying to connect these clinicians, because you can only really coordinate a patient's care from care setting to care setting if you have the doctor speaking to the hospital, speaking to the rehab facility, speaking to the home care needs of that clinician. So you have all of these players in the continuum of care who can only give good care if everybody knows what's going on, if everybody has the most current information, and if everybody is part of the decision-making process, and I include the patient in that, of course. Like that's a integral part of the care plan for any patient. So in addition to the $28 billion that we gave towards adoption, we've also been investing heavily in interoperability. Adoption, sort of we feel like the next step after that is, okay, now we have to connect them all. Now that we have them, most of them with an electronic health record, we have to connect them. $350 million has been spent since 2012 on connecting clinicians within the Medicaid enterprise. So within the Medicaid system, we are connecting hospitals and doctors and nurses and other sorts of specialists, but in sort of a limited amount of ways. What we've now done is, as of February 29th, 2016, we released a new Medicaid letter, which opened up interoperability funding tremendously. Now, as of this announcement, we can use some of that Recovery Act money that's still laying around to connect behavioral health providers, long-term care providers, substance abuse treatment providers, home health, ambulances. I think there's a pitch I heard from somebody who had an ambulance technology interface. Pharmacies, labs, so we can build this sort of broader continuum of care. And as entrepreneurs, I wanted to share that these are the kind of things we want to buy. Like, these are the kind of things that we are throwing federal support behind. And it's not just sort of we, the US government, it's also like we, like healthcare consumers, and in the private payer market, in the employer-based healthcare market, where your employer wants to make sure that their employees have access to the best kinds of interventions for technology. So we're buying these things. And as such, we want to sort of tell you the kind of things we like to buy, because a health information exchange is sort of more than just an abstract concept of a health information exchange. It's made up of parts. And the various parts do various things to help with the interoperable exchange of health information. So there are some sort of maybe 4 or 5 main pieces to a health information exchange, and they're always evolving, they're always getting better. One piece that jumps out is probably the most critical, or at least among the most critical, is a provider directory. Now, I don't know if there's anyone who is familiar with the white pages, a phone book, where you go in, look up somebody else's name, call them. It's essentially an electronic phone book. So one provider sees a patient and can then go to an electronic provider directory that need not be software, it could be cloud-based, web portal, goes to another provider to look up a need to do some sort of referral or transition of care. Like, one provider finds out that, say, the primary care doctor needs to send information to the specialist. They go to the system, look up the specialist. They are then able to use a secure connection to send structured data, or just a note, like an email type note, or structured data that contains things like the patient's labs, the patient's problem list, their pharmacy history, drug allergies, like all sorts of critical information that will help for the treatment of this patient. A provider directory also typically has a sort of a profile page for every doctor. That information usually also has things like where they went to med school, what are they board certified in, are there any sanctions against them, sort of what schedule, like when are they due to take their boards again, that kind of thing. And that information usually lives within a public health department. And so then the provider directory is also connected to public health. So public health then has immunization registries, syndromic surveillance registries, specialty registries around HIV, hepatitis, other sorts of childhood registries that we can then connect bidirectionally to a provider directory to create this sort of source of truth for the providers. So the provider directory is, I think, probably the biggest bang for your buck in terms of health information exchanges. There's also sort of that layer underneath it, the secure messaging, and that sort of permeates all health information exchange activity, that need to send information securely and in a standards-based format. So secure messaging runs through it all, and so your secure messaging might even pop up in other kinds of health information exchange. There's something called encounter alerting that really helps manage patients from setting to setting. So what an encounter alerting is as a patient moves from admission to discharge to transfer, that primary care doctor or maybe a social worker even, maybe a disease manager, wants some sort of system whereby they are notified if there's ever that thing that happens. If you are a surgeon and you discharge a patient and that patient gets admitted to the ER in the next day or two, you're gonna want to know, and that data stream doesn't currently exist. Or at least it exists sort of really within a limited realm within certain health systems, but it's not everywhere. So that feed, that encounter alerting feed, can go to whoever sort of has the authority and wants to know. So if somebody gets discharged from a hospital, we talked about discharge planning and the need for that. If the discharge notice needs to go from the acute care hospital to a rehab facility with detailed discharge instructions, we don't need to worry about a patient carrying a piece of paper with the discharge instructions, or sometimes it's not even them carrying it. Sometimes it's their caregiver carrying the piece of paper, and sometimes some of the directions were verbal. So then they're translated 3 or 4 times as it's come down from the doctor to the caretaker to the facility at the rehab facility. Now we can do this electronically with encounter alerting. Encounter alerting can also just let you know if one of your patients, that you're a social worker who has a HIV patient under his or her care, you get a notice that one of your patients ended up in the ER. You can follow up timely and do what you need to do to properly coordinate care for your patient. And this is especially valuable for patients with multiple chronic conditions. This plus care plan exchange really speaks to those super utilizers, those patients who use a giant share of the money in the healthcare system, but there's actually not a lot of them. They might represent 5 to 10% of your total amount of patients in general, but they might count for 60% of the money spent in the system. So it's a high value target in terms of coordinating care to work with something like a care plan exchange, another piece of a health information exchange. So a care plan is kind of just what it sounds like. It's a collaborative plan that is editable by many sort of clinicians and even some social service providers who might be participating in the care continuum. So you might have a care plan that, let's take, say, a non-compliant diabetic, for example. So a non-compliant diabetic maybe has a nephrologist, an endocrinologist, a cardiologist. They probably have dialysis, so maybe they go to a center, maybe they do it at home, so maybe they have home health care. If they have test strips and whatnot, they'd have more home health care needs. Maybe they've been hospitalized for various things. Maybe they had to go to an ophthalmologist for a procedure on their eyes. So you have all of these sorts of activities. Maybe they have a disease manager who calls them and works with a nutritionist to talk about their diet and exercise. You have all these players, and they're all united around the A1C. They all want to see the patient's A1C and keep it under control, and they all have a shared goal that the patient is involved in. This care plan is a piece of a health information exchange that everybody has access to. Not everybody, like not anybody without a care relationship to the patient. So if you have a care relationship with the patient and you need to be involved, you can all look at the same sheet of music. So everybody can see what it is and edit it and update it and correct mistakes in it. So the care plan is a big tool for those super utilizers that we are finding in the world of accountable care organizations. One of our new models of care is getting sort of high yield. That plus the encounter alerting are really making a difference. We also support what we call query exchange. And query exchange is a little bit simpler sort of to describe, because it's basically just that. It's just, I am a clinician, I have a question about Sam's medical history. I have a specific question about his surgery. I go into health information exchange that houses a clinical data warehouse, and I can pull that information down using a standard protocol. And the protocol is actually probably the trickiest part of the query exchange, because there's not a lot of governance around what that is. when I say governance, what I mean is there's not a real sort of consensus on, okay, when I ask a question, first I have to establish my identity, establish that I am who I am. There is the identity management of also the patient, so that they are who they say they are, or that the person I'm asking about is the person who is housed within the clinical data warehouse, and then that the information can get back to me through what sort of encryption channels or through what sort of certificates. So this process requires a lot of governance, a lot of oversight, and a lot of it is non-technical. A lot of it is somebody sitting around and thinking about the contracts, thinking about the business associate agreements, thinking about the consent models dependent upon your privacy concerns. So that's another thing that we've been supporting. It's called a HISP, a Health Information Service Provider, because they do that administrative piece as well as that technical piece. So that technical piece is important. It's establishing the secure connection. It is looking at encryption standards, looking at all these other pieces, contracts and such, but it's also that administrative work. So it's that sort of sitting down physically in the office, helping the clinicians understand, the contracts, like what they're getting into, and then testing the data and like sending it through. So we started supporting that because it's sort of an abstract governance concept, but it needs money. Like you need to pay somebody to go out and do that. So these sorts of activities for health information exchange aren't solely technical. We've additionally been funding public health systems more and more. Public health systems need to be more nimble. If you are having a sort of outbreak or a potential outbreak situation, maybe it's the Zika virus, maybe it's H1N1 flu, maybe it's any number of new possible things, you sometimes don't have an architecture that supports new diseases because it's a very code sort of standards-based world, and if you don't have a particular code that matches that new disease that you don't have in your system, how are you going to do your biosurveillance? How are you going to track when you have new emerging epidemics or just minor sort of people coming in for complaints that seem to match the complaints consistent with that particular public health concern? You need good data, and you need a system nimble enough to sort of react when there's no sort of standards coding for that particular disease. So we've been championing case reporting and championing sorts of interventions that allow for us to be nimble in our public health tracking. So that said, that's what I want people to start building. Health information exchange systems. There is nowhere to go but up. The letter we released in February, probably if every state that's spending money on this in the United States were to increase their spend 10%, it would go up. It'd be about 150 million more. If they were to increase their spending 30%, it would go up probably 500 million more for health information exchange technologies. And that's sort of on top of what we are already spending, and that's just within one payer. That's not counting anything that is sort of incentivized by Medicare, sort of on the, Medicare is sort of the customer for health information exchange, and there are a lot of movements in that direction to encourage more connected health. So that said, this is a growth industry, and it's also something that hopefully speaks to some of your communitarian interests. Like this is helping people. These interventions save lives. E-prescribing, sending a prescription electronically, saves lives, and we could demonstrably point to the data on that. Certified physician order entry saves lives. Like that's when you have a physician actually order everything online, so the order, the dosage is verified, there's all sorts of checks and balances, saves lives. And again, there's data on this. So the medical errors go down. That said, I'm gonna wrap up and hopefully have lots of thoughtful questions about health information exchange and how everybody can get involved. Thank you for your time. Thank you for the hosts of this conference. And again, please reach out to me with any and all questions about this. Thank you.